Hello, everyone, and welcome to today's webinar. This webinar is brought to you by the Behavioral Health and Wellness Program. We are an organization on the University of Colorado's Anschutz Medicine campus in the School of Medicine. Today's topic is the future of tobacco treatment. And this is the second webinar in a three-part series on our Whole Health Innovation in a Time of Uncertainty project. And we made the decision to broadcast this webinar to a wider audience, and we're excited to see that you've chosen to attend today. So my name is Derek Noland. Just a little bit about myself. I became interested in tobacco while pursuing my master's in public health. I was able to do an internship in Czech Republic studying rates of lung disease there, and also working with the university to do some medical writing, and returned to the United States and joined BHWP, where I have the honor of doing a lot of different public-facing tobacco work.
Hello, everyone. My name is Jim Pavlik, and I've been working in public health, mostly in communications and policy since 2006. I got my start at the Indiana State Department of Health. Eventually, I moved to HHS in Washington, D.C., and then took a brief sojourn away from public health and worked as a social worker in Tucson, Arizona. Like Derek, I do have a degree in English, which is why I think I started off in communications before moving into strategic communications, and then eventually, after getting my master's degree in political science, moving into drug policy from there. I started at BHWP in October of 2013, and I've been here ever since.
Thank you very much, Jim. And so we do have a lot of experience between the two of us doing these types of trainings. We'll have a little bit more information about this at the end of today's webinar, but the Behavioral Health and Wellness Program does run a number of different tobacco and wellness trainings. And should you be interested, we would encourage you to visit our website. And with that, let's start to get into today's webinar. So here are the objectives for today. This was designed to be a forward-looking webinar. So we're looking at both the present situation in terms of the evolving landscape around tobacco treatment. There has been a lot of new developments in the past few years, and it's important to take some time to think through these and how they may impact treatment for tobacco dependence. Also, we want to spend some time looking at the specific value of co-treatment models and the growing impact in substance use disorder treatment. It really has become clear that we need to work on multiple conditions simultaneously. And I will add that in the first section, we'll also have some information on the COVID pandemic and how that relates to this field as well. And then lastly, we'll have a chance to do some even further forward-looking discussions and consider some of the emerging developments that are impacting tobacco use treatment strategies, and even some things that we envision becoming possibilities or likelihoods in the future. Okay, so let's begin with the first section. We're going to, again, look at the landscape of tobacco treatment in terms of some of the present and still evolving challenges. And of course, the one that came to mind first and is the most pressing development in our field, and one that I want to spend a good bit of time on today, is electronic nicotine delivery systems. We use the acronym ENDS as a coverall for all these different types of devices, but they do have a lot of commonalities. As you'll see in our diagram here, all the different ENDS devices do have some sort of battery that powers the device, whether that be a more modern one as in that image at the bottom, or a traditional battery in some of the earlier generation e-cigarettes. Likewise, they all have some sort of heating device that is used in order to heat the e-juice or e-go in the tank or the cartridge, which you can see there. So there are a lot of commonalities between these different devices, but as we'll see in recent years, they have evolved, and now we do need to pay attention to the different types of devices that exist in this field and that are continuing to present themselves here. So let's look at the basic categories within the ENDS family. On the left here, you see our early generation traditional e-cigarettes. These are some of the first products that came on the market, and these were designed to look much like a traditional cigarette, and I'm sure many of you have seen them. When used, often the end will light up and the user will receive a little bit of aerosol or through that device. Now, over time, and I should add that some of these are several decades old, really going back quite a ways. But in the more recent, the last 15, 20 years or so, we start to see development and increasing even further in recent years. So in the middle here, we have a vaporizing pen or a vape pen. So these products were in a they represented a great movement forward in the technology with these devices, and people had more customizability in order to choose the different concentrations of the e-juice inside, for example, more convenience in terms of powering, usage, storage, all those sort of things, advancement here. And also in more recent years, we saw these mods devices. So these on the right here, that larger device, these were more customizable. They were modifiable in that the user could play with the juices and create bigger plumes of smoke and do more tricks with them, as you may have seen in some YouTube videos and things like that. However, over time, what's happened is a lot of people did move from the early generation e-cigarettes to the vaporizing pens, and a small subset of people who wanted more customizability and ability to tinker with the devices moved to the modifiable devices. However, most people did remain in that middle column with the vape pens, and that's really where things stood for quite a few years until the advent of the pod mods. Pod mods being better known perhaps by the term Juul, the main company that really revolutionized this field and kicked off this initiative. So I do want to take a moment and distinguish what it is about Juul and these other pod mod devices that is so unique and so revolutionary in terms of its impact in treating tobacco dependence. Again, there's a lot of commonalities between these devices and the earlier generations. We do see that they have the same basic components, the battery-powered device that provides inhaled doses of nicotine. And I do want to point out that when people are inhaling these devices, they are inhaling aerosols. It's not merely a harmless vapor, which would imply that there's no solid particulate matter in the smoke, the vapor that comes out. It actually is aerosol, and that it does have ultrafine particles that are inhaled into the lungs. Likewise, these pod mods included batteries, and they weren't initially designed to be modifiable, although people have been able to do certain things with them. And they contain some popular flavors, which we had seen previously too. However, there were some key innovations that really helped their growth. They were marketed primarily via Twitter and Instagram, so more of a guerrilla marketing word of mouth approach. And they were marketed heavily by Juul Labs in particular here as a permanent replacement for cigarettes. So, marketed with an improved health in mind, at least marketed that way. And also from a design standpoint, they were thought of as the iPhone of cigarettes. So this is the modern sleek device that would be more attractive to people, that people would want to turn to. Other advantages, easier charging mechanisms through USB port. And initially they did have one concentration of nicotine within the pod. However, there are different options now. And one of the key, really the key innovation is that last point, the nicotine salt formulation. Essentially the technology that Juul developed created an ENDS device that was able to produce a dose of nicotine that would be essentially equivalent to that of a cigarette. And we don't have the detailed evidence to know exactly, but it falls very close to the same amount of nicotine that you would get from a cigarette. And this is a very big development in that the other products were not able to do this. And so this made Juul a much more addictive and pleasurable product, and attract a lot of people for that reason. Before I talk about addressing these products in general, I do want to mention this newer development in this field, the heat not burn products. And the image that you can see there is the IQOS product, which is a Philip Morris product and currently the top product in this field. It has been widespread in Europe and other parts of the world for several years now. It's very popular, in particular in Europe, and the FDA did approve it for sale in the United States in 2019. And so it's something that we need to be aware of as it's going to grow in its popularity and usage. And one of the unique features of this device is that it actually does combust actual tobacco. So in doing so, it does produce aerosols that contain nicotine and other chemicals for inhalation. The industry claims that these products are safer and that they combust the tobacco at a lower temperature and theoretically may reduce fewer toxins in that way. However, there's a complete lack of evidence that this is a beneficial development. And so it will take time before we're able to evaluate whether or not those statements are true. So I want to provide some basic tips for addressing ENDS use. Perhaps some of you are clinicians and may work with people who are using these products. And so we wanted to spend a little bit of time to talk about how we would address them. Um, as with the heat non-burn products, I do want to point out with ENDS products in general, there's a lot of uncertainty about their safety. And while we do recognize that they are safer than traditional cigarettes, that really is only because traditional cigarettes are so incredibly dangerous and deadly and have been proven to be so over the years. So while ENDS may and really do represent an improvement of the health risks of traditional cigarettes, they're by no means safe. And again, it's going to take years before we realize what impact they may have. We're only now getting to the point where people have been using them for years, and to see how a young person who started using in high school, what that might look like in 30 years is really impossible to say right now. We simply do not have that information. But some basic tips to address ENDS use. We do want to listen and acknowledge the user's experience. In this field, as it grows, there's a lot of correct and incorrect information out there. And honestly, as healthcare professionals, we're still learning a lot about these devices. And so, before we correct misinformation that we hear, it is generally a good idea to ask permission to educate people about these devices first. Having received that permission, hopefully we would then educate and address any misconceptions that they might have. And also, I do want to point out that second point that if someone has made the switch from cigarettes exclusively to ENDS devices, we do want to congratulate that success. We don't want to be dismissive of people who are taking the initiative and making positive steps for their health, regardless of the form. And I do want to underline that point that I just made. If someone switches from traditional cigarettes to ENDS devices, it is very important that they completely and totally switch to ENDS products, as even just a single cigarette a day really does impart the majority of harm that one would get from smoking. So again, that's a really important point. Anyone who is looking to use ENDS products to improve their health over traditional cigarettes needs to cut out cigarettes entirely. So some other tips, we want to assist patients in making an abstinence plan. So I don't want anyone to mishear what I just said. Even if someone is moving from cigarettes to ENDS devices, we do ultimately want to get them off nicotine altogether. So that would be where we'd try to ultimately push them. And of course, we can refer people to the quit line for tobacco cessation and other types of resources that they can use. So some other basic recommendations. It is important to let people know about the harms and potentially the harms of use and the benefits of quitting. Letting people know that if they abstain from nicotine altogether, they're going to be more likely to succeed in quitting cigarettes than if they continue to use ENDS, in which case they might be more likely to return to cigarettes. As I noted, we want to correct misinformation when it appears. Some other things that we can do is explore use patterns with the individuals, find out how often they use, different cravings and triggers that they might have, whether they use it socially or not, things like that. We would also, if we're doing a more detailed intervention, we could then design a quit plan, including a quit date and planning around triggers. What we would want to look at addressing behaviors, changing those behaviors, identify social supports that people might have, encourage them to use technology if that would be beneficial. And also I want to note pharmacotherapy, so medicine to try to treat tobacco cessation. There's 7 different FDA-approved medications, and we do see success with those. Adults, this is kind of a benchmark, but it increased quit success 20%. And while these medications aren't recommended for youth, as a last line of defense, it could be a possibility, although they are not, you know, designed for youth use. So another point that I want to address is a lot of people have thought about ENDS products as a cessation device. You see there, many people believe that these devices can help them achieve abstinence from nicotine, or at least from cigarettes and other conventional tobacco products, including even chewing tobacco, things like that. However, that's really not what the research is bearing out. Most people who do switch to ENDS devices are unable to achieve abstinence. So they would either, continue to use ENDS long term or may bounce back and forth between ENDS and cigarettes, regardless, not getting to abstinence. And moreover, people would be more likely to relapse, more than twice as like, or about twice as likely to relapse than they would be to quit the products altogether. So a good chance that people would return to cigarettes. So I want to underscore again that there's only the 7 FDA approved cessation therapies, which are 5 that contain nicotine and 2 medications, and that ENDS devices for the foreseeable future are not approved for cessation, despite what some claims, what some people may claim. So I want to get to a bottom line, and the question is, should I recommend ENDS devices to my patients? And well, let's walk through this, because recommend would be a strong word in this case. But here are the things that we do know. Tobacco smoking is the leading cause of premature morbidity and mortality in the United States. So we're starting from extremely low bar. Tobacco smoke is simply very deadly. And obviously the safest alternative to any sort of nicotine use is abstinence. And for adults, the best option after abstinence would be one of those 7 FDA approved pharmacotherapies. And again, hopefully those pharmacotherapeutic options are ultimately getting people to abstinence. Some people may still have trouble getting rid of nicotine from their systems altogether. They may find the medications unsatisfactory. And some people might even relapse to smoking if that's the case. And for those people, ENDS might be a more attractive option. So for someone who simply cannot quit nicotine and does not find the different medications satisfactory, it would in that particular instance be better for that person to use ENDS devices than it would be traditional cigarettes. However, we must caution that there are unknown dangers associated with long-term use of ENDS products. So again, users of all nicotine products, including both ENDS and the medications, should be encouraged and assisted to become nicotine-free. Ultimately, we want everyone to be nicotine-free so that there's no chance of, or less chance of, relapse and the harms associated with that. So just a couple other complicating challenges that I want to point out that also impact the landscape of tobacco treatment, and then we'll jump into our COVID section. Marijuana use and smoking. So marijuana does contain many of the same carcinogens as tobacco smoke. It does contain numerous harmful chemicals. And another way in which marijuana is complicating tobacco is that a lot of ENDS products can deliver marijuana and nicotine simultaneously. And so these different compounds can both become something that the user is dependent on, and they can prime each other. Situations like that can develop. And I also want to point out that there's definitely an increase among young people using marijuana, which of course will have long-term ramifications in this field. Marijuana use does account for the majority of adolescent substance abuse admissions. So it's not some of the other quote unquote harder drugs. It is marijuana that accounts for the majority of those. And part of the reason for that is that with its legalization and its increase in availability, there's been a reduction in the perceived harmfulness of it, and also a reduction in disapproval of use. So it's becoming more mainstream and widely used among young people and older people. Also want to mention opioids and smoking and the relationship here. A lot of people who smoke do develop chronic pain, particularly back pain. and sometimes may turn to illicit or even prescription use of opioids to treat that. The more research needs to be done on this topic, but it does appear that cross-priming and tolerance between nicotine and opioids is present, so that they may perpetuate the use of one another, and make it more difficult to quit. And so if we look at those treatment outcomes for smokers at the bottom there, we might see an increased opioid withdrawal response, as well as cravings for both of the products, and lower completion of detox regimens and things like that. So we also need to be mindful of marijuana and opioids and other substances too, and the way that they do impact and will continue to impact tobacco as we move forward. So with that, I'm going to switch over to Jim for a few minutes to talk about COVID.
Okay, I think everybody is seeing my screen now and hopefully also hearing my voice. So I'm going to take over just a few minutes here to talk about COVID. I'm not going to certainly hit every topic that would be of concern here, but let's hit some of the high points of what we know now. So back in April, I compiled all the information I could find on the intersection of COVID and nicotine use, and combine that with our own speculation of which subpopulations would bear the brunt of disproportionate harms. Having recently sat through a similar presentation just last week, I could say that most of the information in our April presentation remains relevant, and you can find that presentation on our website if you want more information. I would say that I'm happy that the content that we created back in April is still relevant today, because it's just nice to have evergreen content on your website. But it actually comes from a pretty bad place, which is that there hasn't been nearly as much research in this area as we think is warranted. Which is to say that as an evidence-based program, we are frustratingly still relying on looking at the general effects of smoking on the immune system and on the lungs, and as a causal factor in the comorbidities associated with COVID progression and mortality. And of course, we can also and are still looking at the role smoking played with previous coronavirus epidemics, SARS and MERS, SARS-1 and MERS. So where the science is still on shaky ground is on whether current smokers have a greater chance of getting infected with the disease to begin with. And there's reasons that we suspect that this is the case, and I'll mention those in a bit. And we don't know to what extent quitting smoking protects someone against more severe COVID in the short term. And these are two important questions that remain, and that we think warrants investing more resources to determine. What we can say with confidence isn't much better than this statement quoted here in the final, or back in March, from Berlin et al., if you're interested in that study. Basically, due to the damage done directly to the lungs via smoking, due to smoking's known suppressive effects on the immune system, due to the relationship between smoking and increased infections generally and in respiratory infections in particular, due to smoking's known impact on the ACE2 receptors, due to the association, sometimes causal, between smoking and the development of conditions known to be related to worse COVID outcomes, and because of the epidemiological evidence we've collected since last January, we are extremely confident in saying that current smokers are at much greater risk of having a more severe form of COVID than never smokers, and are much more likely to die from it as well. And that was pretty clear 10 months ago, and it remains pretty clear today. Following this, one thing we know is that individuals are not dying from this disease in a proportionate manner. So seen here are the odds ratios of mortality by race and ethnic category as calculated by the CDC last fall. And one thing to note here right away is that the CDC at the time wasn't even breaking out this data for Indigenous Americans or for Pacific Islanders, which you'll see in a second is pretty important. And when you do that, and when you also account for significantly different age profiles between these groups, you get something more like this. Essentially, all non-white groups, and then also breaking out Hispanics too separately, with the exception of Asians, are dying at over twice the rate of the white population. And it's worth pondering why that might be the case. And there's always a risk whenever we present race or ethnicity breakdowns for data. There's a tendency to think that somehow genetic or some other biological variable is at the root of the differences. But here, as in so many other cases of health disparities, it's simply not the case. Rather, many social imbalances in existence prior to the pandemic have simply just made this pandemic disproportionately worse for certain groups. Basically, each of these groups have increased exposure to the virus due to their occupation or their living situation, or they have reduced access to care and other health-related benefits, reduced access to health-related benefits due to their occupation, their income, or due to previous experiences with the healthcare system that have resulted in less trust in it. And in the context of this talk, it's worth mentioning that all of these things are also associated with higher tobacco use prevalence rates. I've been concentrating on the known role of smoking as a variable of interest with COVID, but since Derek just talked about the rise of vaping as the standard way nicotine is consumed among young people, it's worth pointing out that quite a bit of the increased risk of exposure and aggravated disease profiles are either also true with vaping or suspected of being true with vaping. The first two bullets on this slide are two areas where there are known risks for smokers and are suspected to also be the case for ENDS users. The studies here are limited, but do point in that direction. And the remaining bullet points are true for both smoking and vaping, and in the case of social use among teenagers, perhaps truer for vapers than smokers, in the sense that sharing devices, electronic devices, is a more prominent feature of vaping than sharing cigarettes is.
Thank you, Jim. And let's now look at the role of co-treatment models in terms of substance use disorder and tobacco treatment. And this will be a higher level, more quick moving overview of these topics. I'll mention this again at the end, but the Behavioral Health and Wellness Program on our website, we do have quite a lot of videos and other toolkits that you can download for free that have more extensive information on all of these topics, should you be interested. So I just want to set the stage at the beginning of why this is so important. So you'll see here the trends in US adult smoking over the last 60 or so years. You can see we've made a lot of progress, and currently about 14% of the general adult population are current cigarette smokers. However, you can see that line at the top there, that among people who exhibit an abuse of another drug, we see rates of smoking among that population between 49 and 90%. So substantially higher, and that's regardless of the type of drug. And while that is a big range, it does account for different types of drugs and some of the findings of different studies on this topic. So the important point is that across the board, we do see higher use among other drug use. And so I'm starting to paint the picture of why co-treatment is so important. Looking at another way, we can see that the causes of death from tobacco in our most recent year where the data is available, it does, there are more deaths from tobacco than all of these other different behavioral causes of death combined. And if you look at the left column, that line at the 200,000 mark represents the burden from people with behavioral health conditions. And a lot of these would be people with substance abuse conditions. So clearly bearing a very heavy burden of tobacco. Likewise, it's also worth noting that tobacco use affects mental health care and treatment. And so this is another complication that co-treatment can help us to better address. So people with behavioral health conditions, which would include, again, substance abuse, are more likely to have psychiatric symptoms, increased hospitalizations, and maybe more likely to leave treatment against the advice of their doctor. I also want to point out that they would require a higher dosage of medication, as tobacco does speed up metabolism. And so this can play a role in medications to treat both tobacco and other substances, as well as these comorbidities that are present in that individual, some of these behavioral health conditions. So It's really important that we have coordination, that we're addressing all these conditions at once so that we do get better mental health care and treatment for these conditions. So looking at another statistic, smoking and addiction treatment programs, um, one review over a 22-year span found that the median annual smoking prevalence was 76% in these U.S. addiction treatment programs. So again, setting or making it clear just how interactive and intertwined these two dependencies can be and how it's important that we treat them both connectedly. And so coping through addictions, some basic thoughts that are applicable both to addictions for substances as well as tobacco and really any type of addiction. The same might be true for other types of addictions as well, such as you know gambling or something like that. Most people who have addictions recognize that they're unhealthy and potentially life-threatening, depending on what that addiction or condition may be. And even so, they mistakenly believe that their substance use has a positive psychological function in this regard. And so what we see is that people may use those substances in order to treat some of those symptoms, such as stress, anxiety, and depression. And so essentially they're using this as an indirect coping strategy, which actually reinforces coping through the addiction. And so, that association becomes stronger. The addiction can also become stronger with tolerance becoming higher. You can also see their perceived stress reduction is often actually in reality a relief of withdrawal symptoms. So not accomplishing what we're hoping to by this mechanism. And so another thing that we need to think about or that is worth noting here is that the dopamine reward pathway is a very powerful biological process which drives a lot of our core human desires such as to eat and drink and reproduce. And so all of these substances, and when I say that, I mean nicotine as well as opioids and other drugs, hijack the dopamine reward pathway in a similar manner. And so it's another way in which these are priming us for these dependencies through similar mechanisms and therefore becoming more and more entwined. And so ultimately, the point that I am making here is that an addiction is an addiction is an addiction. So regardless of what product we're talking about here, there are needs that there are certain things that we can do from a treatment perspective that are common regardless of the type of addiction. And we can address things like priming and tolerance and withdrawal. We can treat these things together. And so co-treatment really is the only adequate solution. We can treat all these underlying commonalities that may be there, such as life stressors, different stigmas and bias, different environmental settings that impact individuals, genetic traits, neurobiological traits. All of these things we can address collectively through co-treatment. Okay, and some encouraging findings specific to tobacco cessation. This was a landmark study it's a few years old now, as you can see there, but tobacco use affects treatment and recovery from addiction. And so what this study found is that when we address tobacco dependence during treatment for other substances, so perhaps opioids or other drugs of abuse, we actually see a 25% increase in long-term abstinence rates from alcohol and these other substances. So basically at 6 months out, we see that an extra quarter of people are able to maintain their abstinence rate, their abstinence when they quit tobacco in conjunction with the other drug. And so I think that really highlights just how important it is to pursue co-treatment and to implement those those approaches. So just a quick note on some of the basic things that we can do from a treatment perspective. We do know that dependence really is a two-part problem. You can see there on the left, we have our physical, our biological addiction to the drug. And for that, medication is the best type of treatment. And there's also behavioral dependence on the drug, which can be equally powerful and equally perpetuating. And that's the habit of using the drug. And so treatment really needs to be behavior change programs and other sorts of behavioral treatment strategies. Ultimately, treatment must address both the addiction and the habit in order to have a greater likelihood of succeeding. So just a few behavioral strategies that we know are effective in treating tobacco dependence as well as these other substances. Um, Counseling and support, of course, can be very helpful. Perhaps they implementing such techniques as motivational interviewing or cognitive behavioral therapy. Particularly for tobacco, we know that groups and quit lines can be very effective strategies. And ultimately, we do need to develop ways and help people identify ways to change their behavior. And so all of these behavioral treatments can be effective for co-treatment methods and treating tobacco as well as other substances concurrently. Doing so again may be the most efficient way and effective way in order to do this. And getting to the physical side, I want to talk about medication-assisted treatment for a moment, or MAT as it's commonly known. And this is the combination of the aforementioned behavioral strategies with specific medications that are designed to target the dependence in question. So perhaps one of those 7 FDA-approved medications for tobacco, or a different type of medication if we're talking about treatment for, you know, opioid or alcohol dependence. And so MAT really is a highly effective treatment option for all of these different conditions, as well as for trying to, again, treat them concurrently. Um, and ultimately, this method can reduce illicit drug use and overdose deaths. And of course, as we noted with that earlier slide, can help people to maintain their abstinence from tobacco and avoid relapse back to tobacco. Okay, so that's the overview of co-treatment. I'm going to turn it back to Jim now to look at some thoughts for the future. And I will point out that we'll have a few minutes at the end for questions and discussion. We wanted to make sure to have time for that.
Yeah, no, that's a great point. And I promise that even though I'm going to be talking about quite a bit of issues in the upcoming slides, I'm not going to be taking too much time. Hopefully we'll be done in less than 15 minutes and give us some time to answer some questions. We do have one from Yair in the chat that I think is worth bringing up. So, what follows are a few things that are happening in the wider world that may have some bearing on how we conduct tobacco cessation, or in some cases, who will be conducting tobacco cessation. And I think of all the things I'll be talking about, the one on this slide, if it ever actually advances, come on, there we go, is if I were to be thinking in terms of underrated or overrated, the element on this slide might be the most underrated thing I'll be talking about today. And what I mean by that is that hospital consolidation and the loss of hospitals in our rural areas is, on the one hand, a very, very, very big deal, one with absolutely huge potential impacts for millions of people. And this issue within the health services delivery world is being extensively covered. So that's on the one hand, it's a big issue with lots of coverage. But on the other hand, whenever you hear about this issue, no one is talking about the loss of tobacco cessation services that will occur should this trend continue. And I do want to rush to say that I understand why, when someone is talking about this issue, that they might not immediately leap to the point that tobacco cessation services will no doubt be lost. But before I go too deeply into that aspect, let me talk about what I'm talking about, in case some of you just aren't aware of what's going on. I want to point out that I'm really talking about two different issues with some overlapping factors, but with a similar negative impact on tobacco cessation delivery. First, we have the general loss of hospitals in rural areas, and that's happening for a variety of reasons, but the most important of which is just more and more people moving to the cities. When that happens, hospitals lose their customer base, and the customer base is literally what keeps the lights on in these places. And then secondly, we have hospital consolidation. And what I mean by that is one hospital system buying up independent medical clinics, and also when multiple hospital systems become one system. And these types of mergers and acquisitions, just general consolidation, often lead to shutting down specific physical facilities that are then, after the merger, considered redundant within the larger consolidated network. And this particular thing is happening in both rural and urban areas. So what we really have is a combined effect of consolidation and population loss, sort of doubling the impact in our rural areas. In both cases, though, communities with the highest tobacco use prevalence rates are frequently those communities that end up with reduced access to care. And so that's what we're talking about. And when most journalists and academics cover this issue, they're looking at those spectacular losses to care. They're talking about doctor to patient ratios, emergency room and ICU beds. They're talking about the speedy provision of care after a stroke or heart attack. They're talking about women's healthcare needs and perinatal care. And these things are important, critical losses that can result in the immediate and substantial diminishment of quality of life and, of course, life itself. But it is also the case that for the last several years, we have been medicalizing some problems and therefore making doctors responsible for servicing those issues. And in other cases, we have simply followed the available data and made MDs and DOs responsible for some things because that's who people go to for treatment, even if an MD or the DO is not the right person for the job. In that latter category, as just one example, medical clinics are frequently where people get screened for depression and suicidal thoughts. It might be better if these sorts of screenings were given by psychologists or social workers, individuals with the training and education to treat someone who screens positively at that moment. But the fact is, depression and suicidal thoughts often occur when people have not yet been enrolled into mental health services. But many of them do have a PCP that they see annually or more frequently. And it is also the case that even when someone has access to a mental health care provider, they often seek care for behavioral issues from their medical provider instead. So it has made sense historically to ask primary care to shoulder extra burden in this area, which was fine until the hospitals and clinics started closing and therefore eradicating those providers or relocating them further from the people who need them most. Tobacco dependence is another domain where the labor has been increasingly borne by medical doctors, and with good reason, but it's more of an area that has been medicalized. That is, tobacco dependence, as Derek mentioned, has both a physical and a physical component that should be treated with medicine, and a behavioral component that is best treated with compassionate education, coaching, counseling, and in some cases, therapy. Once nicotine replacement therapy became available, and other drugs too, it's made good sense to refer individuals to their primary care provider for cessation assistance. However, over time, the isolated medical approach has come to dominate the way that we think of nicotine recovery. This is, in and of itself, already problematic, and this problem is only made worse as we eliminate access to medical providers, who in many areas are the only individuals providing this kind of care. And there's no easy fix for this, obviously. But one thing that BHWP has been working on for years is getting both behavioral healthcare providers and other non-healthcare workers trained up in basic tobacco cessation. This is part of our years-long push developing the person-centered tobacco cessation health neighborhood. And one more quick note before advancing to the next topic. If you're interested in some excellent reporting on this particular issue, specifically of rural hospital loss, I highly encourage you to check out the podcast Pictured Here, Where It Hurts. To the best of my knowledge, they also do not discuss the loss of tobacco cessation services as a consequence of hospital loss, but they do an excellent job balancing the systemic and personal consequences of this general trend. The other thing we are looking at is the rise of integrated care and its potential impact on tobacco cessation. Once again, I'll start with a very brief, sort of 30,000-foot view on this topic. So what is integrated care? Well, in short, it's joining mental and medical care in some way. This can be done in a medical neighborhood sort of way, where the mental and medical professionals reside in different buildings and maybe parts of different systems, but they are joined together via a memorandum of understanding or some other method that governs continuity of care. Or it can be done with a single provider, like a nurse practitioner, providing primary care services, case management and navigation services, and even some mental health screening and counseling. Or it can be done literally anywhere in between these two extremes. Primarily what I'm referring to is co-located services, where within a single building or campus, a patient has access to both a medical provider and a behavioral health practitioner who utilizes some kind of transition protocol to guide the patient from one provider to the other should the need arise. And they also have some formalized and routinized way of discussing between them the mental and medical inputs and outputs of their separately provided care. That was a mouthful, I know. There are numerous ways care can be coordinated even under this relatively narrow umbrella of co-located services, but more and more medical institutions are prioritizing limited, brief clinical encounters with the behavioral health provider. These are often 30 to 45 minutes in length or less, and the patient is capped at 3, 4, or 5 visits if they are given more than one. Within those 3 to 5 visits, a determination is made whether the patient is likely to improve given the limited visits or if they will require longer term treatment, at which case they are then referred out. So I want to make this point clear that I sort of organized this section I'm talking in order from worst to best. And I don't think the rise of integrated care is necessarily a bad or a good thing in and of itself. It can really be either, depending on how it's deployed. On the one hand, as I just mentioned on the last slide, and as Derek has already said, nicotine dependence is a physical and a behavioral health issue, and having both sides treated at the same time by a joint mental medical effort under the same roof, that's the best way to provide the most effective and efficient level of treatment. However, even after, say, a 6-week long psychoeducational group, we know that many, maybe even most individuals require additional support if they are to persist in their abstinence goals. It is extremely common for a psychoeducational group to have somewhere between 25 and 30% success at the end of 4 to 6 group sessions, but half of those individuals will have relapsed by 6 months without support, which means most individuals receiving tobacco cessation support in an integrated care environment will be well outside the range of allowed services if what is currently the most dominant model continues to maintain and shore up that dominance. Now, this is only problematic if integrated care is obliged to refer individuals for longer services and there's no one to refer them to, or if the only people that they can be referred to are not acceptable for some reason or another. They only exist at substance abuse treatment facilities that might have stigma for individuals, quote unquote, only working on nicotine. Or perhaps the hospital can only refer to independent therapists, counselors, or psychologists who are not boarded by insurance and can only accept out-of-pocket pay or something like that. Again, maybe this isn't a concern in a major metropolitan area where there are plenty of available providers and access to safety net providers. But in some urban health deserts and in most rural areas, this is going to be a major problem. Although I do rush to add that integrated care is not the issue here. It's more that integrated care doesn't solve this issue for the groups that we have the most concerns about. And the same thing could be said, I didn't bring it up as a slide, but the same thing could be said of telehealth. Telehealth holds a lot of promise for extending care to hard to reach populations and areas, but we shouldn't fall prey to the illusion that it solves access issues for everyone. And we need to be mindful of the shortcomings of promising practices like telehealth and integrated care, even as we rush to embrace them because of their clear benefits. So now I want to move into some of the more clearly good news elements. First, we have potential improvements in pharmacotherapy. And I do want to stress that pharmacotherapy, as much as having access to it is desired, as much as I field questions about it from parents and smokers and behavioral health organizations and public health agencies, it's probably the most overrated thing I'm talking about. And that's not to say it isn't good. Pharmacotherapy is very good, and it has quite high cessation rates even when used in isolation. In terms of its bang for the intervention buck, providing meds is easily the best thing that a provider can do. That said, it doesn't, in my estimation, deserve quite the esteem that it often gets. That said, one area where we could definitely make some gains is in the approval of existing medicines, in this case specifically nortriptyline. Nortriptyline, like bupropion, is an FDA-approved antidepressant that has some evidence of efficacy as a tobacco cessation medicine. However, unlike bupropion, nortriptyline is not FDA-approved for tobacco cessation. Given that it's a known commodity in the depression treatment world with a known side effect profile, I don't see any reason why it shouldn't be given first-line status for tobacco cessation as it is in the UK and elsewhere. I haven't heard any news that this is happening, but we're on the lookout for it nevertheless. This would not be an earth-shattering change if it happens, but it would probably be a good thing. It would probably be a good thing if it did. Similarly, another medical option that there used to be a lot of buzz about that seems to have died down is the development of a nicotine vaccine. This is, just as it sounds, an intervention that would cause the body to create antibodies to nicotine, preventing the drug from being absorbed across the blood-brain barrier. This has some analogs in the alcohol treatment space. I'm particularly interested in this potential development as we move away from cigarettes and toward vaping as our main way of taking in nicotine. Moving on down the list, the patent for varenicline expired last May 2020. Varenicline is currently sold as Chantix in the US and Champix abroad. However, this could change at literally any time. Before COVID, the expectation was that a generic competitor would roll out as early as June 2020. And to the best of my knowledge, none has. Now, there's probably a good reason that a generic hasn't been made available in the US yet, but it's definitely going to be coming. And varenicline has the highest cessation rates of the 7 currently FDA-approved tobacco cessation drugs. Making it more affordable could be an absolute game changer for millions of current tobacco users. And by the next bullet point, I'm not actually saying I want an improved version of varenicline, although that potential actually exists if we start to see an arms race for the best generic varenicline. What I'm referring to is some other cessation drug that has better cessation rate than NRT or varenicline. Again, I don't know of any good candidates and certainly nothing on the immediate horizon, but this possibility is always in front of us. Moving on to a medical vape pen. With nicotine salts, as Derek mentioned, the new formulation in the pod mods, we now have a method of delivering a very precisely controlled dose of nicotine. It's an absolute no-brainer from here to add in electronic or computational control over that dose so that it delivers a specific effect tailored to the individual user. In fact, I'm essentially right now describing technology that does in fact already exist for marijuana, created by the same company that currently makes Juul back when they were called Pax Labs. From there, it would be easy to create a titrating schedule, also tailored to that individual, and with that process, create a medical vape pen. Again, I don't know of any company currently working on an electronic device designed to help quit nicotine that will be marketed that way, but I suspect that something somewhere is already in the works here. And the final bullet, it's not medicine itself, but the final thing in this category, and Derek's already brought this up, is better alignment with current MAT protocols, medication assisted treatment protocols. Most institutions, unfortunately, that do utilize MAT already aren't really focused or prioritizing nicotine treatment. That's places like substance abuse treatment facilities, jails, and prisons. As such, this is more of an intellectual or philosophical barrier for now. However, in large part due to the opioid epidemic and more recently because of our respiratory pandemic, we are seeing more rapid buy-in to this idea over the last few years, and I would expect that trend to continue. And finally, I want to talk about tobacco treatment specialists. For those who don't know, the tobacco treatment specialist is exactly what it sounds like, someone with specific training in assisting people in exploring their relationship to tobacco, co-designing a treatment plan with the tobacco user, and then supporting that tobacco user and following their plan until they're comfortably abstinent. Many people have the title tobacco treatment specialist as a result of their job duties. But a few years ago, a set of core competencies for this professional were established. Following this, about a dozen organizations became accredited to provide training in those core competencies. And a few years after that, a national certification was developed. In the next few years, we would like to see and anticipate seeing their role continue to be professionalized. Among our goals at BHWP are to see more TTSs certified, to see more certified TTSs deployed and more effectively deployed, and eventually to see certified TTSs be listed as qualified providers under CMS so they can be reimbursed for their services. And of course, not just Medicare and Medicaid, but actually all insurers, ideally. And that wraps up my comments for today.
Thank you very much, Jim. And I do want to draw everyone's attention to our website. Again, that second bullet point there, down there at the bottom, bhwellness.org. You can find more information about some of our trainings, including our very own Rocky Mountain Tobacco Treatment Specialist program and other trainings, and a lot more information on some of the points that we've talked about today. You can also contact us via those mechanisms there, that phone number and our generic email address, which Jim, myself, and some other members of our team check. And we do want to give an opportunity if there are any questions at this time from the audience about some of the topics that we've covered today. We'd be happy to address those.
So Derek, I'll toss this one to you. Yaira did chat one in way back before we started going off on demographics. But she said, she asked, some people don't necessarily move from e-cigs to ends with an attempt to quit. And she asked how we would address that. So basically somebody who's moved to ends for recreational reasons, it sounds like.
Hmm. That's a very good question, and there certainly are people who are doing that, and of course, people who are, starting with ends and not using cigarettes. The first thing that we would want to do to underline my point from earlier is make sure that they are not using cigarettes whatsoever, that they're at least only using ends. We'd also want to find out why they're using ends. What sort of role is that playing for them, and what other sort of behaviors or other things that they could do in order to meet that need and hopefully move off the ends product altogether. We of course want to let them know about the potential health risks and the unknown long-term risks with those products too.
Yeah, we collected some data on that particular question several years ago now. At the time, it was through the Quitline, and it was something like 80 or 90%, give or take, of callers to the Quitline who are using ends were doing so to quit cigarettes or to cut back on cigarettes, one or the other. And they all, something like 72% of them, if I remember that number right, wanted to eventually quit ends. Now, that was back when Quitline only offered services to 18 and above. Quitline now currently treats individuals as young as 12. So we were looking at specifically adults, and they're a slightly different demographic in the terms of their ends use. So at that time, we saw a lot of people who really were using ends in that way with that intent. Now, I'm not so sure that that's the case. A lot of young people, electronic devices are their first and only device. They are clearly adopting it for recreational and social reasons. And so this is going to become more and more important. But to Derek's point, we can't make people quit. We want to make sure that we want to properly calibrate their perception of risk. It's not perfect, right? But we definitely don't want them backsliding into cigarettes. So somewhere in there. And of course, as healthcare providers, we always want to be encouraging people to make more healthful choices. And so always making sure that we are a trusted resource for them so that when they're ready to make a move in the right direction, we are there to support them.
And if anyone would like to, chime in, we're happy to unmute you so that you could ask the question directly as well. And I see we have a question that just came in.
Jamie, for those of you who can't read the chat, this is a great question from Jamie Stutz. I'm sorry if I just butchered your last name. She said she's happy that we mentioned vaccines. Like I said, like the enthusiasm seems to have dwindled because we haven't been able to get a sustained response from them. And I don't know. The final question, and part of the question was any opportunities with new vaccine tech, and I don't know. I wish I knew. This is not an area of expertise for me at all. I think that, well, I mean, I could talk about some things, but the short answer is I don't know. And I hope that with the new mRNA vaccine style, or even with the new lipid profiles, we're able to develop these lipid shells around the mRNA. There's a potential there, but I'm not the right person to ask. I am looking out for it though. I'm waiting just as much as you are.
Any other questions? Still got a couple minutes. If anyone has anything they'd like to ask, now's your chance. Oh, a question about the recording of this training. So we do plan to upload this webinar to our website. It will be under that Whole Health in a Time of Uncertainty project page. So be on the lookout for that. It should be up there in a week or so.
Yair has a nice closing quote, comment here that she says, many behavioral health providers are not trained in integrated care or substance use in general, and closing this training gap will help tremendously in increasing access to tobacco cessation in rural areas where FQHC, for example, are the only providers in the area. And I absolutely 100% agree. And this is an area where historically, this is where BHWP does a lot of work, and that is training individuals in behavioral health how to handle tobacco cessation. And also, for that matter, we train a lot of doctors and medical providers how to do this work. We're trying to bridge that mental medical gap as an institution. That is exactly what we're in for. So, or in this for. So I 100% agree that we need to close that gap. And Yair, if you want to write letters and get us more out into rural areas, I'm happy to go. Teresa's asked how they can access the recording. Derek, did you actually say? Okay. Great.
Yes, we'll have that up. Let me, I'll post that link to our website again in the bottom there in the chat box for anyone who didn't catch it on the slideshow there.
Drew, we have talked about this. Drew, hit me up online. There's no official guidelines and protocols for nicotine replacement therapy. There are things that we can do. They have some caveats and problems, but they're actually the same problems and caveats that exist with assigning nicotine replacement therapy for cigarette use. We kind of just need to get a good picture of the volume, benchmark our nicotine replacement dose to the nicotine that we suspect they're getting from their general product, their product of choice, and then use their own reflection on the magnitude of their cravings to adjust up or down depending on their actual experience, normally up. And then once we actually have their cravings managed, start titrating them down from there. That's the general rule. So, there are milligrams per milliliter dosage on all the Ego vials and all the Juul vial or Juul pods. And so we kind of use that as a rough estimate of how much nicotine somebody's getting, and then we benchmark and go down from there. But you can hit me up offline, Drew. You know where I live.
We have another good comment from Jamie. I'm appreciating that we mentioned, the role in treating comorbid substance use collectively. However, I'm pointing out the reality that a lot of professionals are entrenched in this sort of let's treat one at a time, and we're fighting that fight, trying to present the evidence that really does point to the opposite being true. So yes, this is a challenge that still exists and that we'll continue to chip away at, and hopefully all of you will as well. All right, and with that, want to thank everyone for attending today's webinar. Again, please check out our website for more information on any of these topics, and we hope you found today's presentation useful and enjoyable. Thank you.